Thank you. I'd like to start by thanking the organizers for giving me this opportunity. So my job is to quickly provide an overview of what is coming through the treatment pipeline in terms of drugs. None of these are yet approved, so this is all work in progress. So here are my conflicts. Most importantly, please note, the opinions that I'm going to express are my personal opinions. Okay, so the first thing when you think about treatment, you need to put it in the context of the disease. And in the context of NASH, there are really two critical stages. One, before cirrhosis develops, and then once cirrhosis develops, then you start getting complications, liver failure, ultimately death. And the causes of mortality are a little bit different before cirrhosis develops and then after cirrhosis develops. So before cirrhosis develops, cardiovascular mortality and cancer-related mortality are the leading causes of excess mortality in people with NASH, whereas liver-related mortality is very rare. Once cirrhosis develops, then suddenly liver-related mortality becomes very important. And although cardiovascular and cancer-related mortality is still important, liver-related mortality becomes a bigger deal. So when we think about treatment, you have to think about what is it that you are trying to fix or prevent. So in the pre-cirrhotic stage, you definitely want to reduce cardiovascular outcomes, cancer-related outcomes. And since people are not dying from liver disease at this point, that's really not an outcome of interest at this stage. But what you are interested in is preventing development of cirrhosis, which in turn can lead to liver-related outcomes. Now, once cirrhosis develops, then you are more interested in directly demonstrating that your treatment is preventing liver-related outcomes. Anything short of this is not sufficient. So when we think about treatments, one of the things that has emerged from this extraordinary amount of basic science and translational physiology that we have learned about the pathogenesis of NASH that Helena outlined so beautifully, it has given us a lot of different targets for treatment. So what I'd like to do is simplify this for you by breaking it down into where these drugs work. So if you think about the disease, it starts with metabolic stress, which produces cell injury and cell death, which in turn triggers an inflammatory response. If it's only transient, the inflammation gets rid of the dead cells, you go back to normal. But when cell injury is constant and death is constant, inflammation becomes constant and self-perpetuating, which leads to a scarring reaction in the liver, which ultimately leads to cirrhosis. So if you think about it rationally, the most rational treatment is to treat the root cause, which is the delivery of excess metabolic substrate to the liver, which is what Marco was talking about. But if you cannot do that adequately, then the first step is to treat the metabolic part of the disease. And that is done through a variety of targets. And the first set of targets that were studied were the PPAR gamma, because insulin resistance is central to the development of this disease, and PPAR gamma is central to insulin resistance because it's an insulin modifier. So pioglitazone was the first drug studied, but it had a number of limitations. But what it turns out is that the benefits of pioglitazone are mediated not by PPAR gamma, but by specific pathways within the mitochondria called mitochondrial target of thiazolidinediones. So this has led to two types of development. One, where you have drugs that are directly acting on these mTORs so that you can have the benefits of pioglitazone without the side effects of pioglitazone, such as weight gain, fluid retention, etc. And there is a study which will finish next year. We will hear about it. Also, people have developed new enantiomers of pioglitazone so that the dextroenantiomer of the pioglitazone molecule acts through these pathways and has all the beneficial effects without the weight gain, which is associated with the levoenantiomer of pioglitazone. We also know that in addition to PPAR gamma, if you take PPAR alpha and delta, you can also get benefit for NASH. PPAR alpha makes you burn the fat, oxidize it in the liver, and PPAR delta inhibits macrophage function and reduces inflammation. And elafibranor is a PPAR alpha delta, which has now been studied. And in a phase 2b trial, although the primary endpoint was not met with a priori endpoints, when they were asked to reevaluate their case definitions using criteria that are used by the NASH CRN, we find that in those who had high activity with the activity score more than 4 and who had F123 fibrosis, as shown in yellow, you can see that the drug indeed was beneficial. This is currently in pivotal trials and in many countries in Europe and in the US, and we will have the results in about a year, year and a half from now, and it may be one of the first few drugs to actually be approved for NASH. In addition to PPARs, there are also another class of molecules called FXR agonists, which are bile acid receptor agonists. Now, bile acid receptors are very important because they send signals to the body that nutrition is coming, and they actually lead to intracellular signaling that adjusts our metabolic rate. So INT-747, or obeticholic acid, is a synthetic derivative of a natural bile acid called quinodeoxycholic acid, where you add an extra ethyl group, which increases the agonism for FXR many fold, over 100-fold to be precise. So we did an initial study showing that it actually improved insulin resistance. And then this is the result from the Flint trial that was also done by the NASH Clinical Research Network. And going from left to right, we show the proportion of people who benefited from this drug. In the blue arm is the drug, white is the placebo. And you can see the primary endpoint of NAFLD activity score, much higher proportion for obeticholic acid, same for steatosis, inflammation, ballooning, even fibrosis. So this is the first time that we actually demonstrate improvement in fibrosis in NASH with the oral compound. But the number of patients with resolution of NASH, the disease doesn't go away. That number is still very small, only about 20% compared to about 13% background in placebo. One big problem though with the OCA is that when you prevent cholesterol from being converted into bile acids, which is what FXR agonists do, that extra cholesterol comes out, and that extra cholesterol can lead to increased LDL. And we already know that in NASH, there is an increase in free cholesterol because of dysregulation of cholesterol synthesis. And this free cholesterol comes out, and in the end, you have high levels of LDL cholesterol. And at the same time, the LDL receptor expression is suppressed. So whatever LDL cholesterol is in the circulation has greater contact time with the endothelium and can promote atherosclerosis. So you have a further increase in the setting of FXR agonists. So obeticholic acid, which blocks conversion of free cholesterol into bile acids, increases the amount of free cholesterol that eventually comes out in LDL cholesterol. So to get around this, there has been a lot of pharmaceutical activity, and this is a first compound that has now moved into human trials, and this is called LJN-452 from Novartis. And when you take bile acid receptor, FXR agonist, by mouth, in the intestine it binds the FXR, and that causes release of a compound, a molecule called FGF19, which feeds back on the liver. So here what you see is both at low dose and at high dose, the FGF19 goes up, meaning that there was target engagement. The drug actually bound the target, but the LDL cholesterol remains flat. So this is now in phase 2 studies, and we will present the data for the phase 2 at ASLD. I'm not allowed to present that data here, because I'm bound by the federal rules about that. But hopefully many of you will come to ASLD, we'll be able to show you that data. Another compound is the FGF19 molecule itself. FGF19 feeds back and has many of the same function on the liver as FXR agonists do directly. It can reverse steatohepatitis in animal models, reduce hepatocellular injury, and even reduce fibrosis. So a phase 2 study was conducted where not only non-invasive markers were looked at, but also patients were biopsied 12 weeks after being put on treatment. What you can see on the left is that actually a number of patients improved their fibrosis, even in this very small period of time. And many of these patients had big improvement in steatosis, which is shown in blue. The blue bars are the number of people who improved. And you can see that there's a significant number of people who improved steatosis, inflammation, ballooning, and even some with fibrosis. Now, many of this was accompanied by improvement in various non-invasive markers within 6 weeks, particularly liver fat, assessed by MR, PDFF, which is shown in blue on the right-hand side. And you can see that this compound actually is a very potent compound. There are two problems with this compound, three actually. Some people get diarrhea. Number two, you get the same, it's an injectable, so you have to, they have to figure out an oral way of doing this. And number three is that this also causes an increase in LDL cholesterol. So that has to be resolved. Aramcol is another very interesting molecule where you take the bile acid and you put a fatty acid at its end. And when you do that, it blocks a key enzyme called sterol-CoA desaturase, which is involved in de novo lipogenesis and synthesis of fat in the liver. And in a phase 2A study, it produced a dose-dependent improvement in liver fat. The phase 2B study has now been completed. The results have been submitted as a late breaker to ASLD, and we hope that it'll be accepted, so then we will present the data over there. So this list continues to grow. Another very interesting compound is FGF21, which is not the same as FGF19. This is not a mitogenic cytokine. It is produced in adipocytes as well as in the liver, and it has direct antifibrotic effects as well as insulin sensitizing effects. It also causes weight loss. And we have shown this year that it actually reduces liver fat in a phase 2A trial, and also improves liver enzymes, causes adiponectin levels to go up, and improves insulin sensitivity. A very exciting class of molecules that also work at the metabolic end are these thyroxine beta receptor agonists. Thyroxine beta receptors are mainly in the liver, and these compounds have been shown to reduce cholesterol, triglyceride, and so they were also studied for NASH. And what you see is the data over here with these Madrigal, which is the company that makes these molecules. The Madrigal 3196 is the molecule that was studied. You can see compared to the little gray bars, substantially greater number of people with improvement in steatosis, ALT, as well as AST, which occurred in about 60 to 70% of people who got this drug. Very exciting, but then they followed it up with a biopsy done at 9 months. And if you look at the biopsy, unfortunately, the numbers were not quite as dramatic. A decrease in NAS score was seen in about 32%, but only 6% people actually resolved their steatohepatitis. There's still work needs to be done to improve on these therapeutics. From my perspective, a very exciting class of molecules are the GLP-1 agonists. GLP-1 agonists are increasingly being used for diabetes, have been shown to improve all-cause mortality as well as cardiovascular events in patients with diabetes, which is the population at highest risk of having NASH with advanced fibrosis. In a very small study from UK, they showed that liraglutide actually significantly improved NASH resolution and actually even improved fibrosis. So we need larger data. But if they can reproduce this in larger populations, then this is very, very exciting class of molecules. We, of course, should not forget that bariatric surgery works. It is very well described now that it improves even liver fibrosis. but you're producing a permanent anatomic change in the patient. It is not something that you just do and tell the patient to go home and have a nice life. Those patients need very close medical follow-up. So there are pros and cons to doing bariatric surgery. It is a powerful treatment, but it is not the treatment. It is a treatment, it is not the treatment of NASH. So where do we stand with therapeutics? You know, after all this talk, we all love the new drugs, but if you look at this graph, the first two set of bars on the left are the data for the old drugs, pioglitazone and vitamin E. None of the new drugs come close to the effect size of these two compounds. So you can advertise and jump up and down and go to all the drug company symposia you want to, but I will ask them to beat this bar. Unless they can jump over this bar, they have accomplished nothing. So the bar is set for the pharmaceutical industry, and through the NASH CRN, we're going to keep pushing that bar higher so that patients will ultimately benefit from therapeutics. What about going downstream? I just showed you the data for vitamin E. There's a very exciting molecule called ASK1, which is at the interface of oxidative stress and inflammation. This was studied, I'm sorry about these slides, somehow between when I loaded it and over here, everything is over on top of each other. So GSS 4997 is the ASK1 inhibitor that also showed benefit and is now in pivotal trials which are fully enrolled. So we will have the results next year. The NGM data on the left are the FGF19 data that I had showed you previously. And just for sake of comparison, on the far right, you are seeing the Madrigal thyroxine beta receptor and the O-beta-cholic acid data. Going further down, it becomes more and more challenging. At the interface of inflammation and fibrosis are chemokine receptors. And this drug, cenicriviroc, specifically blocks this. And these are the final results of a phase 2b trial called Centaur. And what you see over here, first on the left, that people who improved, 30% of the people who improved their fibrosis in the beginning, 60% of them, the next set of bars, maintained that fibrosis improvement. So it produces durable improvement in fibrosis. And on the right-hand side, what you're seeing are the number of people, proportion of people who had two-stage improvement in fibrosis, because histology can sometimes mislead you because of sampling variability. So if you look at two-stage improvement in fibrosis, it's 11% versus 3%, yet not dramatic numbers, but at least it's moving in the right direction. These drugs, this compound is also in phase 3 trials, but it's probably going to take another couple of years before you see the results from this. The rest of the drugs in the antifibrotic range have been somewhat disappointing. We already had published data from a molecule called simtuzumab, which was completely negative. I'm not going to show you the data. More recently this year, data from a study using a drug called galectin was published. And as you can see, hepatic venous pressure gradient was the primary endpoint, placebo response shown in the first two bars, low dose drug in the next two bars, and you see no difference. And then again, at the high dose, baseline versus week 54, no significant difference. So somewhat rather disappointing overall with this. So where do we go from here? We need to continue to develop better drugs, more effective drugs, and safer drugs. But ultimately, given the multitude of pathways involved in NASH, we are going to need combination therapeutics. So if you look at disease activity as the primary driver of disease fibrosis, which you put on the y-axis, you can divide this into 4 quadrants. Those with low activity and low fibrosis can be managed with lifestyle alone. Now, of course, lifestyle is for everybody. If you have high activity, but yes, at this point, not much fibrosis, you probably just need a metabolically acting drug because there is no fibrosis. You don't need antifibrotic at this stage. Those who already have a lot of activity and a lot of fibrosis, they are ideal for combination therapeutics. And those who have burnt out cirrhosis, you need a major, strong antifibrotic therapy for those individuals. We're already beginning to move into this area. These are data presented at EASL earlier this year. And what you see are cilonsertib, which is the ASK1 inhibitor, an ACC inhibitor, and an FXR inhibitor used separately and in combinations. You see the reduction in liver fat over here. But what's interesting to me is if you just have a pure ACC inhibitor, the results are better than with the combination, even though the numbers are not significantly different. And also, if you look at pure FXR, it seems to be better than combining it with selonsertib. At least the trends are going not in the direction you would hope for. So again, this underlines that we need a lot more work to be done to improve on the therapeutics for NASH. So many drugs are in development. They will need to demonstrate histological improvement in the short term, but in the end, they have to demonstrate clinically meaningful benefit, which is what we started off with. If you do not yet have cirrhosis, it should reduce the likelihood of developing cirrhosis. If you have developed cirrhosis, it should reduce liver-related outcomes. Otherwise, you're treating yourself. Thank you.